Welcome to Speech Scope, a MedBridge podcast where we conquer challenging topics for the medical SLP. Our aim is to deliver actionable takeaways for clinicians like you through captivating discussions with experts in our field. To receive continuing education credit for this episode and access bonus resources, make sure to check out medbridge.com. Hello, I'm your host, Sarah Baar, a clinical SLP in Michigan with over 15 years of experience. I specialize in adult neurogenic disorders and the life participation approach.
Today, I'm excited to be joined by Dr. Patricia Geels, an expert in the area of cancer-related cognitive impairments. We'll be diving deeper into this topic, including recent research and actionable takeaways you can implement right away. Welcome, Trish. Can you get us started by telling us a little bit more about yourself?
Hi, Sarah. Thanks for having me. I am a speech language pathologist. I have over 10 years of experience, primarily working with adults with neurogenic disorders across the continuum of care. The majority of my time was at a level 2 trauma center. At some point in that period, I switched over to academia, and in 2023, I completed a PhD in interdisciplinary health sciences. And I'm currently an assistant professor at IU South Bend, and I teach courses related to adult neurogenic communication disorders, voice, and research methods.
Fantastic. I really loved talking to people who've had just not a completely straightforward clinical journey. And so I wanted to take a minute and hear about your clinical journey, both how you got interested in cancer-related cognitive impairments and also how you ultimately transitioned from the clinical side of practice to the research side of practice.
Oh my gosh, Sarah, such a great question. I have been all over the map. I went through all of graduate school thinking I wanted to be a school-based SLP, and then had a really great experience during one of my externships and quickly switched paths into the medical setting. My specific interest in cancer-related cognitive impairment stems from conversations with the neuropsychologist on my rehabilitation team. When I was a relatively new clinician, we were just discussing the ways that as a team, we could expand our rehabilitation services beyond our facility's sort of standard practice of treating strokes and head injuries. And we realized that we shared an interest in serving the needs of our oncology patients. And so we started to work on pitching the idea of what at the time was known as chemo brain to the oncology department. As anybody who's worked in healthcare will understand, there was a lot of red tape, and sometimes things just can't get off the ground. And so there was a lot of changes and turnover in that department, so we couldn't get it going. But when I began considering a PhD, this topic seemed like a really natural fit for the PhD experience, and the faculty at Western Michigan was just so incredibly supportive. And so I used that educational opportunity to begin describing what the faculty there describe as a clinical irritation, which this has always been for me. So I jumped into research with a topic that I had started out in the clinical world.
Oh, that's so cool. And I love that term, the clinical irritation. So if any listeners are thinking about what they might want to do their PhD, I think we all have clinical irritation. So that's a good way to start it.
Yeah.
I'm excited to learn from you today. To be honest, I was someone who's still I thought we called it chemo brain. And it's cool to hear that things have progressed and we now have the term cancer-related cognitive impairment. I thought maybe a nice place to start for our conversation would just be talking about that term. So what do we mean by this and why is this important to discuss today?
Oh, absolutely. So cancer-related cognitive impairment, or CRCI, it is a big term that refers to the cognitive communication difficulties experienced by many cancer survivors during or even after treatment. You may have heard of this, like we said, as chemo brain, but these difficulties often include changes in attention, memory, processing speed, executive functions, and language. We know that CRCI can affect up to 80% of survivors during active treatment, and it can persist for years or even decades in some individuals. Although most people experience improvements in their cognitive function once treatment has been concluded, a significant portion, 20 to 30%, continue to experience cognitive issues long-term. Like I said, even decades after they've concluded treatment. And when we think about the importance of this topic, we have to think about our role as SLPs in the idea of cancer survivorship. We know that cancer survival rates have improved significantly over the past few decades, which means that more people are living with the lasting effects of cancer and its treatment. We know that CRCI can limit survivors' ability to return to normal daily activities, and this will impact their personal and professional lives. So when we think about CRCI, if we can develop a better understanding of this, it allows us to support the health and well-being of cancer survivors, and it also just helps the healthcare team provide better care.
That's wonderful. Just a question about that terminology. So do you feel like people who specialize in oncology, like they're using that term CRCI, or is that like newer?
I would say it's probably been within the past 10 years from what I can tell in the research. There is some variability. So if you search for cancer-related cognitive dysfunction, you might see that. Sometimes it's cancer-associated, but generally it's in the ballpark. And most of the literature is using CRCI.
Cool. That's awesome. And kind of good for us to make sure we're updating our terminology also. You are the author of not one, but 2 articles about cancer-related cognitive impairment that were published this year. Congratulations.
Yeah.
I'd love to hear more about your research, like what you learned, what you did. So do you mind spending some time telling us about your research and the highlights?
Oh, not at all. These 2 papers are, they're ones that were based in surveying cancer survivors. So I want to first start out by saying I am endlessly grateful for the people who shared their experiences with me. The first paper aimed to investigate just the prevalence of cognitive communication deficits in adult cancer survivors, and to just assess the impact of these deficits on their social engagement and their satisfaction with social roles. So I utilized a cross-sectional survey design to gather data from these adult survivors, looking at demographics, how they rated their own impairments, as well as their social engagement and satisfaction with social participation. The majority of my participants had stage 2 breast cancer, and the findings revealed significant self-perceived impairments across a variety of cognitive communication domains, but particularly in everyday communication. Participants indicated greater difficulties in social roles and activities compared with their overall satisfaction with their social participation. And these results, for me, really highlight the multidimensional nature of CRCI and stress the need to address both cognitive communication and social elements in our care. Given the nature of the impairments that are reported, these results really do suggest that SLPs can play a vital role in identifying and addressing the cognitive communication deficits associated with CRCI.
So, like, am I hearing like you really found like a whole spattering of impairment? So it's not like it's like, okay, very consistently people have this, but just like broadly, there's a lot of different things that can pop up as part of this. And also it's not just like that impairment-based testing, but really like talking to people about how it's impacted their everyday life, their friendships, their relationships, their work roles, their parent roles, like all of that stuff. Is that kind of what?
That is absolutely where I went with this. I actually did not administer any standardized assessments for my participants. It was strictly based on patient-reported outcome measures because I wanted to get at what they were feeling, what they were experiencing, because I think we've all found with other etiologies that sometimes there can be a discrepancy between what a patient reports and what our standardized testing finds. And I felt like there was real value in understanding their lived experience of this phenomenon first.
Completely agreed. That's wonderful. Okay, cool. Continue on, my friend. Second paper.
So the second one I wanted to explore help-seeking behaviors and who and how are people looking for help for this issue. Essentially, I just wanted to find out, is there a difference between someone who seeks help for this disorder and someone who doesn't? Because if we know who seeks help and who doesn't, it helps us to better understand how we can reach those people. So this study drew from the same pool of participants. And it was kind of interesting to me. Over 25% of participants did seek some form of support, primarily speaking with healthcare providers, but they also engaged in independent searching on the web. And they also looked to personal connections. So spouses, friends, adult children, they spoke with people in their lives. And these were the most common sources of assistance. When I asked what types of interventions they participated in, some people took medications. A lot of people reported physical activity. Some went to counseling to address the mental health issues related to this. But when 25% seek help, that means that 75% did not. And so knowing this, I looked at the qualitative data. I used thematic analysis to see what were the barriers to seeking help when you noted that you had cancer-related cognitive impairment. Some themes that emerged out of this were just a lack of awareness of this as a side effect of cancer and treatment, but also feeling reluctant to seek help, viewing CRCI as relatively insignificant compared to the other issues that were going on, and not receiving sufficient validation from healthcare professionals regarding their complaints. And so for me, the results emphasize the need for improved collaboration between oncology and us in rehabilitation, but also working to disseminate information so that patients are equipped to understand what they're going through, so that we can support them.
Yeah. So I just want to make sure I have the numbers right. So when you say like 75% of participants did not seek help, did all of those experience symptoms like this? Okay. So wow, that's super high.
Yeah. It was really substantial. Looking at what were barriers to seeking help was not an original part of my research goal, but it was just such a striking finding that I couldn't leave that question unexplored.
You're like, I need to understand more about this first.
Exactly. Yeah.
Okay. Well, thanks for asking those questions and starting the research on this topic. It's pretty evident, right, that there's more to do here, and especially more in the SLP's world and role of how can we help be a facilitator for that? So from what you learned from your studies, I'd love to spend some time thinking about how clinical SLPs listening to our chat could translate what we know right now into what the actions that they're doing. So first of all, my question is, with cancer-related cognitive impairment, is there a type of criteria of client that is more likely to experience this? So I'm unfamiliar. Are there certain treatment types or cancer types or length of treatment? Who are the at-risk clients that we might come across our offices?
Such a great question. The short answer is we're still figuring that out. Okay. But we do know that there is a complex interplay of factors that can include cancer type, what type of treatment was received, what are your demographic characteristics, and your individual health history that may influence the development and persistence of CRCI. So when we consider the risk factors associated with CRCI, one of the primary considerations is, as you said, the type of cancer that a patient has been diagnosed with. So we know that research indicates that survivors of breast cancer frequently report higher levels of cognitive deficits. Similarly, we see those who have been diagnosed with hematological cancers, so leukemia and lymphoma, these people are also at increased risk. This vulnerability can be exacerbated in patients whose treatment involves neurotoxic agents, and obviously the presence of a metastatic brain tumor can directly impact cognitive functioning. We know that the treatment regimens themselves play a significant role in the likelihood of experiencing CRCI. Chemotherapy is the original sort of treatment modality thought to be what is causing this. Okay. Particularly when we know that some of these agents are neurotoxic. But we also know that hormonal therapies have also been associated with cognitive changes. The length and intensity of treatment also matters. So the longer you're in treatment, the more rigorous and intense it is and hard on your body, that can play a factor in this as well. Research shows that longer durations of chemotherapy and more cumulative doses of neurotoxic agents correlate with a higher incidence of cognitive impairment. And then finally, we just know patients undergoing multiple cycles of treatment often report greater cognitive difficulties. But we can't forget that, especially when we start to think about the social determinants of health, demographics play a significant role in determining who might be more susceptible to CRCI. Age is a critical factor. We know that older adults tend to be more vulnerable to these cognitive communication deficits, likely due to pre-existing cognitive decline that may have been exacerbated by their cancer treatment. There's some evidence to suggest that gender might influence cognitive outcomes, with women, particularly breast cancer survivors, reporting higher instances of CRCI. But this is something that we need to explore more, because we need to have more data about men.
Yeah. Okay.
And then finally, just the mental health issues like depression or anxiety. This can really amplify that experience of CRCI, and social factors. So mental health and social factors go hand in hand. A strong support system can mitigate cognitive difficulties, while a lack of social support and feelings of isolation can intensify the perception of cognitive impairment.
Wow. That's all so interesting. And I can also appreciate at the same time, like, yeah, we don't really have like hard, fast rules. And so basically for SLPs, having people post cancer treatment coming through their offices, asking questions about it and validating the experience is kind of where we're at right now. It's not like, well, you didn't meet this criteria, but if they're reporting changes, like they're reporting changes.
Exactly.
Yeah. One of your articles highlighted the small amount of clients who did do those help-seeking behaviors when they experienced the cancer-related cognitive impairment. I'm still having that has to roll off my tongue still. Do you say the whole thing, or do you just say CRCI?
I usually just say CRCI.
Okay. I'll try that. I'm going to try that next time. Okay. So what ideas do you have for a clinical SLP to engage in their places of work, so that maybe that opportunity could be increased for the clients to be referred to speech therapy and to start like working on some support and some treatments for those symptoms?
Okay, so this is something I'm very excited about. I think that we can be really strong advocates, especially when speaking with oncologists. I think oncologists are phenomenal, but they have so much on their plates. And if there's a way that we could begin with a clinical SLP, if you can work with your oncology department on integrating cognitive communication screenings into routine care. We're all used to doing this for depression and anxiety at the doctor's office. This is a great start. We can educate our fellow healthcare professionals about CRCI, as well as the role of SLPs, because we are all familiar with but he talks just fine, he doesn't need speech. And so being able to advocate for the profession while we're advocating for our patients, those two things can go hand in hand.
Absolutely. Yes.
We can also raise awareness among survivors. Many don't recognize that there is at least the potential for improvement with treatment. And so we can offer educational materials, workshops, participation in survivorship programs, just to inform survivors about CRCI and the potential benefits of speech therapy. And when we think about what we found about barriers to help seeking, it's something to think about. I would encourage clinical SLPs to think about the feasibility and their desire to potentially provide group therapy sessions or telehealth sessions to reduce the burden of accessing care for patients. We know that CRCI is a newer area of research, so we're still, as a collective of speech pathologists and rehab and oncology and rehab together, we're figuring out how to care for this population. And so as part of my next research project, I'm hoping to explore what SLPs who have more day-to-day experiences with this population are doing in their sessions, so that we can better understand effective clinical practice.
Awesome. Yeah. So just kind of that next step, like, okay, once they're coming, like, what are the most helpful ways to spend time?
Yeah.
I like your ideas about, moving things forward to try to capture those referrals in the first place. And I even wonder, I guess my thoughts are like that, more in that like preventative realm. Like, could SLPs working, in a facility or hospital system with oncology, like kind of just create a little, hey, if you notice any of these symptoms, like this is possible, and, talk to your doctor, and like you can have a referral to SLP. So kind of, I don't know. I'm trying to decide if that would like scare people to say like, this is possible after cancer treatment to have changes like this, or, would it help to educate them on the front end, like look out for this and then let us know? Or would we want to like put that more on like the oncologist to ask about it?
Well, and those are all really great questions. And those are some of the things that we still need to figure out.
Yeah.
I think the cancer experience is unique in the different etiologies that we work with, in that it's not a single event that occurs. Yeah. There are multiple treatments, sometimes setbacks, sometimes huge gains, sometimes something is okay. One of the things that people brought up was, I just couldn't deal with one more thing.
Right.
Yeah. And so I think you bring up a good point about, we still need to figure out when is the best time to support someone. Yeah. I think one of the things that came through to me in the research was just normalizing it and saying, this is not okay, but it is common enough. And being able to say, if you want to try something, we would be willing to work with you.
Yeah, huge. Right. Just letting people feel like heard and understood and validated in a really hard situation, it makes a difference. Yeah. So another thought in my head is working with oncologists. I actually did do some of this about 10 years ago in a hospital, and sometimes they can be a little scary. I'm just going to say that. So I would love to hear your recommendations for like talking points or word choices when you are trying to get some of this interdisciplinary stuff going on, or like maybe you have someone who's like, I've been practicing for 20 years and we don't do, I don't really do any of that stuff. I don't know. I'd love to hear, you have such a refreshing way about you. What has worked for you, or what ideas do you have?
I think that this is one of those, I feel like this is possibly the wait and see approach for adults. Like, it's just like, for kids. And I think that this is one of those things. When you're working with healthcare professionals, oncologists, nurse navigators, social workers, it would really make the time and effort to emphasize that CRCI is just a well-documented side effect of cancer. This isn't something that just shows up anecdotally. This is a real thing. And so encouraging oncology practices to incorporate those cognitive screenings into their follow-up care can help to identify these deficits early. I think using concepts or ideas or terms like chemo brain or mental fog can make the concept relatable, but also bringing it back to, this is a real phenomenon and we can collaborate to help make this better. When we are interfacing with patients or care partners, I think simple but compassionate language goes a long way to building that therapeutic alliance. I think we can explain that it's normal to feel like their brain isn't working the way that it used to before the cancer diagnosis, and to reassure them that the cognitive changes are real. Using phrases like thinking problems or memory challenges can help make CRCI more relatable, and we can emphasize that there are strategies and therapies available to help them manage the changes and improve their daily life. But in all of these conversations, again, I keep bringing it back to normalizing, but I'd focus on normalizing the experience and also using our time to provide hope that with the right support, potentially like with speech therapy, survivors can see improvement.
Yeah. Excellent. Thank you. That's perfect. Your research really struck a note with me because, like we briefly talked about, you didn't just talk about the cancer-related cognitive impairment as like, here's this list of impairments, but you really focused in on that social participation, how quality of life or social roles were impacted. So knowing this, I'd like to hear more from you about the assessment tasks that you might recommend for clinical SLPs. I know you mentioned you didn't do impairment-based testing. So tell us a little bit more about how you're thinking about that assessment piece.
Oh, I love this part. Because we know that CRCI affects individuals and how they engage in their daily lives. It, as you said, it influences social participation and it can just really reduce your overall quality of life. And so I think to address these broader effects, integrating those patient-reported outcome measures can help us capture our clients' perspectives and perceptions of their challenges in real-world settings. There are tools like the Functional Assessment of Cancer Therapy Cognitive Function, or the FACT-COG. This is designed for cancer survivors and assesses self-reported cognitive impairments, abilities, and quality of life. Another tool, and the one that I used in my study, is the Cognitive Communication Checklist for Acquired Brain Injury, the CCC-ABI. This was originally created for brain injury, but it can be adapted for CRCI to quickly assess functional cognitive communication challenges.
Awesome. Do you think that we could include like the links to those in our handout for after the podcast so people could just
for sure.
We'll do that then for anybody listening. That's great.
Yeah. And when we think about assessments, in addition to patient-reported outcome measures, it's really important to include functional tasks that stimulate real-world cognitive communication demands. These tasks offer us measurable, objective data on how the clients handle cognitive communication challenges in those everyday environments. So, for example, conversational analysis can uncover difficulties with maintaining focus, managing topics, sustaining attention in social settings. Role play scenarios that mimic the workplace or social interactions can also help us assess how clients cope with cognitive fatigue or communication breakdowns in real time. So often, I know we talked about how age and older adults are particularly vulnerable, but younger adults who are still managing things like parent-teacher conferences and going to soccer games and doing all of these things, we need to make sure that they can navigate those experiences well.
Yeah.
And so also when we think about, we recognize that there is a significant effect on emotional and social well-being. Using quality of life assessments alongside our cognitive measures is really important. There is a suite of sort of patient-reported outcome measures called the Neuro Quality of Life, NeuroQual. And this is a tool for evaluating how someone is impacted on emotional, cognitive, or social functioning scales. There's a wide range of tools, and you can integrate those into your practice. And they're all available online, so we can probably include a link to those too.
Totally. I actually did a webinar at MedBridge on patient-reported outcome measures, and we have a link to that one. So that's we'll include a link here too. And the nice thing is, it's not just like you getting the client's perspective, which is super important, but you're getting a quantity, like you're measuring it. And so you can really use that to then measure again at the end of your treatment to show how treatment has impacted things like quality of life. So that's my favorite.
I love that too. I think sometimes the things that we are attempting to measure can be hard to measure, but quality of life, it's a good thing to know.
Yeah,
it's a good thing to know. I also think when we think about all of this assessment process, assessments generally result in goals. And so if we're moving beyond our formal assessments, collaborative goal setting can be crucial for ensuring that therapy focuses on the aspects of cognitive communication that matter the most to the client. So the client might want to improve communication at work because returning to work after chemo, surgery, radiation is hugely important to them and their sense of self. And so maybe that's what they're looking for. Maybe they're looking to manage fatigue in social situations. And so personalized goals can help us to address those impairment-based deficits that we've noticed, but it helps us to do that in a way that addresses their specific needs.
Awesome. Very good. This really ties right in. So when you're setting those personalized goals, can you speak to how treatment time or intervention might be impacted, like either through what you learned in your research or just kind of continuing on, like making it personalized to what the client is reporting as a problem?
So this is something where I have yet to find a whole lot of research that's out there. So we're building that knowledge base. And in some ways, I'm kind of advocating for us to build the plane while we're flying it.
I know it's exciting, right? But it's also like, oh, shoot, wish we knew that like right now.
Exactly. I think a jumping off point that's helpful for us is that the clinical profile of CRCI shows some pretty striking similarities to cognitive impairments that we have seen in individuals recovering from COVID-19. Both populations experience cognitive communication deficits ranging from attention to memory to word finding. We see executive functioning deficits. And I think given this overlap, it might be useful or a good jumping off point to sort of borrow some of the practices that we're already using with our COVID-associated cognitive impairments while we're still researching best practices for CRCI.
Great tip. Yeah.
I think also thinking about time and how to support someone, is if you are going to be integrating patient-reported outcomes, it has a possible effect on the amount of time it takes to complete an intake. But tools like the FACT-COG or the CCC-ABI, these help to ensure that treatment is effective and personalized. And so if we front load a little bit of extra time, it potentially can really allow us to provide targeted interventions that might reduce the amount of time that someone is in therapy. And I also think that when we are working with our younger survivors, a return to normal is really important. I mean, study after study just shows that they really want to get back to normal. And so emphasizing those real world tasks and through role play scenarios can help us to facilitate improvements in their overall quality of life. And again, time-based things, collaborative goal setting, it can take more time. But again, I think that it helps to facilitate the therapeutic alliance. It helps to make sure that we are targeting what is most important in this moment for that person.
Yes.
And so I think when a client or a patient has been heard, they're far more likely to engage in the work that you've asked them to do on off days.
Yeah.
Right. And also just collaborating with other healthcare professionals can potentially complicate treatment planning, but I think it improves effectiveness.
Yes. That's it's kind of like, I'm thinking of like short-term pain, long-term gain.
Yes.
Like, okay, yes, like maybe we're rearranging how we're doing things, starting to do patient-reported outcome measures. It might feel like an extra step if you're starting, but like in the long term, it is helping your treatment be more specific and then efficient. So that's kind of how I'm thinking about what you're saying.
Well, and I think about like if we go back to our neuroanatomy classes, like, and you think about the principles of neuroplasticity. So salience matters, repetition matters. And so the more times you get comfortable with, okay, I'm going to talk to the oncologist and I'm going to tell them what I can do and I'm going to reach out. Then the next time you have to have that conversation, it's a little bit easier because you've already done it once.
Yes.
And so by engaging in these conversations, we can get comfortable with something that might be a little bit uncomfortable to begin with.
That's good encouragement. So, it's normal for the first time to start to engage in that way. That might feel a little difficult and it's going to get easier.
It's going to get easier.
Okay, this has been so interesting to learn about your research. So talking maximum impact, what would be your top three actionable takeaways that you would like clinicians to put into practice?
Okay, so I'm going to lead with what I think is a researcher favorite line, which is, we're still learning. So this is an emerging area of practice for us as SLPs. And as we continue to learn, our strategies might evolve. But I think we can support the people in front of us today by incorporating those patient-reported outcome measures. We know these measures provide insights into their self-perceptions of deficits and quality of life, and by regularly using these outcome measures, we can tailor our interventions to address their specific needs and challenges, leading to more targeted and effective therapy. I think we should develop treatment plans that prioritize functional communication tasks and real-life scenarios. Again, we're looking to enhance relevance in practicing skills that they will use every day. And I think we also need to, a natural outcome of that is we need to incorporate our clients into the goal setting process, particularly in an oncology situation where there's going to be ups and downs and person's ability to participate may change depending on where they are in a treatment cycle. Mm-hmm. And so we know that this collaborative approach can foster motivation and commitment, also allows our goals to evolve as someone goes through the treatment experience.
Mm-hmm. That's great. That actually brings up a little question. Yeah. Do you have recommendations? So you mentioned kind of the fluctuation that can happen when someone's going through treatment. Any recommendations on your end about like, okay, let's wait until treatment is done and then begin addressing some of these challenge areas, or are we doing it at the same time, or is it patient by patient specific, like kind of what they're up for?
I would lean probably towards the latter. I think it probably is going to be patient by patient and seeing how it works. The sort of scary thing is that among oncology patients more broadly, rehab referrals, I think it's reported that only like 5% of oncology patients receive a rehab referral for PT, OT, and speech combined. So we're really not capturing this population. We're not serving them as well as we could. And so while we're still learning, I would strongly advocate for a patient-by-patient approach. I would be prepared for a backup plan of like, okay, if today's a 5 and not a 10 sort of energy level day, here's some things you can do. Yeah. Okay, we're having a 3 day, here's what you can do. Oh, no, oh, great, we're having a 7, here's what you can do. Being able to help someone scale up or down depending on their side effects, just their general energy levels, how they're feeling.
Beautiful. Wonderful. Okay. Awesome advice, Trish. Thank you so much. I would love it if you could talk us through, as the audience, a hypothetical case example.
Okay. So I created, she's hypothetical. We're working with Jessica. She is a 45-year-old breast cancer survivor who recently completed chemotherapy. She comes to our office. She's reporting difficulties with concentration, memory, some issues with social interactions, particularly at work. She's back to work now, having some trouble with this. So during the initial assessment, our SLP administers formal assessments using the tools that are available in her office. We don't know every SLP clinic is a little bit different. So they're using what's available in the office to evaluate Jessica's cognitive abilities using those impairment-based tests. But as the SLP is also going to incorporate the functional assessment of cancer therapy cognitive function, that FACT-COG, to capture Jessica's self-perceived cognitive challenges and how these are affecting her social engagement. Through Jessica's responses, the SLP is learning that Jessica feels especially challenged in maintaining attention during meetings and is concerned about word-finding difficulties. So together, they set collaborative goals, focusing on her desire to participate more actively in the workplace. So we've got our assessment done, and the SLP is thinking, okay, well, how am I going to achieve this? Yep. And so the SLP designs functional communication exercises that simulate workplace scenarios. So let's practice being on a Teams call. Let's practice working through a sort of more active meeting-based environment. We can also work on brainstorming sessions, working through presentations. And also in the intervention process, the lovely thing about being a speech pathologist is that the assessment process doesn't stop when you've started billing for intervention. And so by regularly incorporating those patient-reported outcome measures in our follow-up sessions, the clinician can track Jessica's progress and begin to adjust interventions to meet her changing needs more effectively.
Ooh, I love that. Okay, so One, I just feel like so many warm fuzzies thinking about like, okay, we are putting away the worksheets. We're not doing the card games. We're not naming animals in a category. We're actually practicing strategies and like role playing the things she's going to need to do so that when she goes back to do it, she's more equipped and feels more confident and like has a couple tools in her toolbox, basically.
Yeah.
That makes me so happy. And what I also heard you say is then when you can re-give some of those measures like the CCABI and you're like using that to say like, oh, okay, this was working for this, or, oh, let me change that a little bit because I don't think we impacted that. And you're continually getting feedback and like together adjusting the plan. It's beautiful.
And I feel like as clinicians, I feel like one of our roles is to remind people of how far they've come. Because so often in my clinical practice, someone would they would sort of feel really down on themselves because like, well, I'm still in the hospital and I'm still struggling. And it's like, whoa, my friend, you have really come so far. And part of the joy is being the holder of the data. And being able to say like, look at how far you've come. Yeah. And so I think those patient-reported outcome measures, like all of this, it gets to facilitate an experience of growth. And joy and learning and recovery.
Oh, yeah, because when they're going through it, it is harder. When you're living it, it's harder to recognize it. So, what a cool job we have to be able to be that person to share that. This has been really such a wonderful discussion, Trish, and I wanted to just offer you a minute as we wrap up to offer any final words of wisdom or inspiration that you want to leave with the audience.
I think this will probably not be earth-shattering to anybody who's tuning in. But in the same way that a stroke or a traumatic brain injury doesn't define a life, cancer doesn't have to define a life either. And we can, as speech-language pathologists, we can use our unique skill set to support patients as they navigate this particular aspect of survivorship. It's a big task, and we can use our skills to help make a part of this better.
I love it. Thank you so much, Trish. Thanks for leaning into your clinical irritation and helping like move along some solutions. I honestly look forward to your work and seeing where else this goes. I appreciate you taking the time to be with us today and share your insight and the clinical takeaways related to cancer-related cognitive impairment. Thank you.
It's been a joy. Thank you for having me.
Thank you for tuning in to this episode of Speech Scope by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or on your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Speech Scope also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcasts@medbridge.com.